So it's not coincident that February is the heart month, right? So it's a good talk to talk about the heart in February. So we're going to focus a lot on a lot of studies a little bit. Of course, I'm here to talk about symptoms and how they can trick all of us. And of course, we're going to focus on women. And why heart? Because people mostly and sadly die because of heart problems. So it's a big burden nationally and internationally. There is a pendulum and the heart awareness, the heart disease, we're living longer, we're getting older, so that's why the burden is happening. So 900,000 deaths a year, at least 500,000, 500,000 people die suddenly. This is, even sometimes we don't know about them. Somebody had a car accident, somebody was home, found home, all those, what we call sudden cardiac death. We try to be very precise about those because we need autopsy. So not everyone who dies suddenly dies because of such and such and such. So autopsy helps us define the unknown sometimes, and even in some cases still unknown. So remember, I started a couple of minutes ago, at least 2 people died because of heart disease. So every minute there is a woman, every 30 seconds there is somebody. A person dies because of heart disease, a lot. So that's a big burden, right? Some of that, and that's why we're talking here, are preventable. I was told one time there is no good theory than a very good practical theory. So the best theory is the most practical theory. So this idea of this talk was between me and Abigail, who is the nurse reviewer in our hospital, and she's sitting in the back there. A case, a female who had symptoms of burning in the stomach, burning down in the stomach. So all the testing, EKGs, blood work, and then eventually scopes for the stomach and ultrasound of gallbladder surgery, and pain was not going away. We ended with bypass surgery. So that's where this idea came from. This is just a little bit of a slide to tell us what's the global burden in men and women, and how did that change. This is men, this is women. Here we're talking about how much we are losing days because of coronary disease, heart disease as such. And there is a big, big burden. This is death because of heart failure. I want you to remember this slide for coming up slides later on when we talk about risk factors. The highest burden and death of heart failure is down here, right? Look at the color. Southeast states. There is a reason this doesn't happen, nothing happens because of coincidence, right? So remember, women are mostly concerned about breast cancer, right? Breast cancer. Well, we lose more women because of heart disease than lung cancer. There is so much research about breast cancer, but we need to be aware of heart disease. That's the key. Okay. So look, lung cancer, lung and breast cancer. I meant to say breast cancer, which is down here. So coronary disease is the blue. It's way higher, way higher. Number 1 cause of death is coronary disease and heart problems. This is to show you the trend back in the days and coming up between men and women. You see the trend going up, going up. Awareness, thankfully, is getting more and more. 1997 and coming up to 2012, of course, we looked at white, Hispanic, and African Americans. And, of course, the awareness, thankfully, and, of course, February month and other campaigns and other doctors being more vigilant about women complaining of symptoms caused more awareness. Famous people. I'm just going to bring a few pictures about famous people we know, all of us know, who had coronary disease. Bill Clinton, 2003, 2004, he had bypass surgery. before his bypass surgery, he passed 3 stress tests. Okay, so in 2013, he had stents again. George Bush, he had coronary disease as well. He had, and the father did as well. Dick Cheney, and we know our famous CNN talker. Dick Cheney went farther. He had a heart transplant, and I'm sure everyone knows that. I'm gonna get right. Oh yeah. Excuse me. I had to bring 2 females here, famous females. This is heart failure and aortic disease, but again, heart problems on our famous Taylor and Rowe. Now, let's talk more anatomy here. Heart is about the size of your fist. Doesn't matter if you're 130 pounds or you're 340 pounds or 500 pounds. The heart is about the size of a fist. Doesn't grow with our size. At age 18, that's it, you got your growth, that's about your size of your heart. So every extra weight you have is just a burden in your engine, right? So I think about it, and let's just, I'm gonna stop for a second here. The ideas I got is from my patient asking me questions. That's how this talk came here. So the slides, okay? Patient asking me questions. So it doesn't matter if I go through my slides, I just want to get ideas for you back. So I think about the heart as a car engine. Okay, you have the electrical system, you have the valves, you have the engine, you have the pipes. Okay, so the RPMs on your engine are how many rotation per minute? The heart beats are the RPMs. If you have an extra load in your car or going uphill, your RPMs go higher. That's exactly in the heart. Extra weight make the heart works harder. Okay. So all of us are born with 3 arteries, 2 on the left, coming from a main artery called left main, and 1 on the right side. Those are the main arteries. But I brought this second slide to show the arteries become arterioles, smaller and smaller, because they have to feed cells. So, yes, sometimes we don't have blockages in the big arteries, but guess what? We have blockages in the smaller ones. So, visually, sometimes we can't see them. But clinically, we can say, yes, they are there, based on some testing, of course. So, how to come to reality to say you have coronary disease? The 100% listening. So, we listen to our patients. History and physical exam. We try to categorize patients, low risk, moderate risk, or high risk, based on their risk factors, profile, and as such. Because if somebody comes and tells me, 40 years old, on a treadmill every day, I get chest pain watching TV. You're on a treadmill every morning doing 3-4 miles, you don't get chest pain, you got it one evening on TV, just watching a few minutes. My threshold is low. Somebody who has diabetes, smoking, hypertension, he has all my sensors looking for something. Okay. So, exam is essential. And the key, how do they speak about their presentation? We try to help patient. Language is different. Everyone is different. The patient presentation, the way they describe their symptoms are different. Everyone's different. We have different fingerprints. So everyone is different. So everyone deserves a different impression. There are common grounds, but different always. So we do EKGs, simple. They're not so sensitive. We miss a lot. They can read wrong. Computer reads a lot wrong. 50% is wrong. So our training teach us to say and decide what's right and what's wrong. So arrhythmias and heart attacks, all the computer says, oh, there's a heart attack. No, there's not. But the computer says so. The computer is fed by variables, but there are, again, differences. Patients sometimes born with a right side heart instead of left heart side. Some patients have COPD. Their lungs are not as such normal lungs, so the EKG can read a lot of wrong things. So we don't listen to the EKG. Of course, we need it as a helpful tool. It's just a tool. Okay. Stress test, exercise, or somebody cannot walk on treadmill, we give them medication to stress their heart. They have knee pain, they have hip surgery, they have back pain, they can't run on a treadmill. The best stress test is running. The best stress test is to do functional stress test. But, of course, we have elderly people, we have patients who have back and knee and all that, and they can't exercise. So we do medication to stress their heart. And look, we have with and without imaging. So we do echocardiogram, which is ultrasound of the heart, or we do what we call nuclear stress test to look at the heart function and there is any blood perfusion problem. And sometimes, let's say, we do a stress test based on risk factors and profile. A lot of us ignore the stress test because even it's normal, that doesn't speak about what you're speaking of. So we still go farther for heart catheterization. Or if you come to us, you give us a good story. Oh, doc, every time I go across the parking lot, I have this pressure sensation. I get short breath. I can't, every time I do it. Not I do it today and next week it's gone for 3-4 months, it comes back one day. That's unlikely. But consistency, because the heart does not lie. Heart is consistent. It's a muscle that if it doesn't get blood, it's going to hurt. Or it's going to give you a symptom, which we're going to talk about. So sometimes what I'm trying to say, we skip the whole stress test because everything fills in the right symptom. We go to heart cath. Or we do a stress test and based on that we decide. So what's angina? Angina is a Latin name. Angina, that's the Latin name. Suffocation, that's where it came from, okay? So it's an old Greek name. It's an old description in the medical literature, 1772. We have what we call typical angina and atypical angina. So typical angina, that's the symptom whenever you exert, there is a symptom. Atypical angina, there is a sudden onset and symptom. Now a blockage is cascading to a severe range to the point you have symptom arrest. You have symptoms with much less. I used to golf every day, now I can't. That's unstable. Stable angina, I get symptoms where I get up the stairs, but I'm fine. I've been having that for such a long time. Stable angina. Blockages, this is just a picture of an artery, are complex. They're complex composition of plaque, which is lipid, cholesterol, and calcium. They start happening as early as 18 years old, even 16 years old. So this is how they start. Build up, build up, build up, and then they obstruct slowly. If I go back here to the point where the blood flow is really impeded, and that's when we start having symptoms. Okay. They're sometimes vague. And the vagueness comes from the name of the vagal nerve. The vagal nerve is nerve from the brain, it's number 10. We have 12 nerves coming from our cranium. So, and the nerve name is the vagal nerve. Enough said there. So the vagal nerve, interesting, doesn't go only to the heart. It has all this distribution. Stomach, esophagus, lungs, even the bladder, intestine, all of it. You wonder why people get dizzy, why people get nauseous, why people get diaphoretic. This is why. That's the vagal nerve. Okay? And that's, just to add on our confusion, just the name of vague symptoms. Okay. Now we're going to talk about men and women. Okay, so this is an old slide. So, figure. So we'll try to find the on-off, of course. We're going to do that. So I'm going to present a couple of studies looked at specifically women's symptoms. We all think about heart attack, chest pain. No, that doesn't happen always. Chest pain, yes, is the common ground, the most common, but fatigue can be 70%. Sleep disorders, shortness of breath. Look at chest pain. This is one study, 29%. Okay. At the time of heart attack, this is before, at the time of heart attack, shortness of breath, again, chest pain, 57. It's not 100%. Okay, good. This is another study. There are what we call prodrome, before. Some females feel something is wrong. I'm tired, I'm short of breath. Something is not right. It's hard to catch this. Yes, it can happen because of a cold, it can happen because of other flight or sleep disorders, all that, right? So, but the chest pain is not always there. That's the key, okay? So another study here, they looked at, again, chest pain, which was on this study more common, but again, look at the fatigue, shortness of breath. And by the way, they don't have to happen all of them together. So they can happen couple, 3 of them, they don't happen all together. And sweating, of course. And this is just to compare men and women. Now, the quality of chest pain. And it's different. So some people describe it as pressure, or you see the textbook description, an elephant sitting on my chest. Yes, that's good, but if you don't have it, doesn't mean there is no problem. So we look for stabbing pain, we look for aching, we look all of that, heaviness, and the dull even, okay. And percentage-wise, look, I mean, pressure, mostly pressure, but it can happen just that sharp stabbing pain, 40%, so almost half. So I hope this is gonna work. Let's see if it's gonna work. This is oh, it did not. I'm trying to show an angiogram of a coronary angiogram, heart catheterization. So another picture of the heart and the blockages. The plaque got to the point where it's severe enough to hinder the blood. There's an obstructive lesion here. And when this happens, a clot starts forming. So now I'm going to stop here and talk about other entity. So does the blockage have to be 70, 80, 90% to cause a death? No. Even young people die, which is unfortunate, at their 40s and 50s because of what we call plaque rupture. So what happens, a piece of even 30% or 40% plaque can rupture. So if that ruptures, the body thinks, the blood is there flowing inside the artery. There is a wound. The blood doesn't know. The platelets, they think there is a wound. I have to stop that injury. And they start aggregating and forming a clot. And that's a big heart attack. The prognosis on those are worse on the prognosis on this 80 or 90% blockage. Why is that? The heart, the muscle down the flow, down the cascade of a severe blockage is used to low blood flow. The young guy who had a plaque rupture and sudden abrupt stop of blood flow is not used to it. Sudden cardiac death. Make sense? So that's a problem. So we'll talk about how do we stabilize this? How do we prevent that. But that's the unfortunate thing. So even there's no what we call benign plaque. Plaques are dangerous. This is a picture of angiogram. So the catheter usually comes up here, and this is what you see here, coronary artery 3 on the left side with contrast. The contrast is like water, but looks dark black under X-ray. Anybody had stents here? Ooh, okay. So you've seen this, right? So probably we do heart catheterization with minimal or any sedation. So sometimes you see the monitor. So you see this on a live moving picture, which I'm sorry, my video didn't work. So, and that is a severe blockage. Another one, 2 severe blockages. You see how the flow is just as like crunch the apple, severe? Okay, okay. So when we see that, now we do need to fix it. So that's how we do stents. You see that wire coming through the artery here, that has a stent loaded on it. We inflate the stent and you see the blood flow going through now. So that's how we do the stenting if there is severe blockage causing a problem. We had evolution of stents, all started in 1960s with steps, generations. Initially we didn't have stents, we did only balloons. Initially we didn't have those great medications, which we're the blood thinners for the stents. Now we have great ones. Medicine came a long way with that. The final generation of stents are bioabsorbable stents. So the body absorbs this and becomes part of your body. So the question sometimes the questions become, okay, I have a stent, would you replace that? No, it's become part of your body. We don't replace stents. If we have to, we do a stent inside a stent. So, and we started the latest generation of stents, of course, we have what we call chemical, like chemotherapy coated stents. Like same chemotherapy we use for breast cancer, lung cancer, everolimus, Taxus. So all those, tacrolimus, all those stents are coated inside with cancer medication that, of course, the body takes care of low doses so that the artery does not grow inside the stent. That's why the idea of this. So to keep the flow from stopping. So the latest generation of stents now is in Europe. We don't have it. It's going to come here, but we have here in the United States what we call bioabsorbable stents. Now, in the past, we used to do Plavix, Ticagrelor, and another Prasugrel. Those are medication we use for stents for a year or longer. In Europe, the stents have become so evolutional that you can stop blood thinner after 3 months. So, which is great. Now, does every blockage need a stent? The answer is no. The answer is no. And everyone, every nurse practitioner, every family medicine doctor, every doctor should know this study. It's called the COURAGE study. The COURAGE study. The COURAGE study started early 2000. So it's a huge, great landmark for us, all physicians. So again, not every blockage needs a stent. Because if we do, how many of us will be, I might need a stent. So we'll be walking just for the stents. So what did this study do? Okay, they looked at patients with stable angina meaning they have stable symptoms. When they exert themselves, they have chest pressure. We know they have blockages, but 70% even, but their symptoms are stable. The symptoms are stable. That was the key. On medical therapy, that's another key. And they followed them for initially 5 years, and a couple of years ago we did have the 15 years follow-up, which is a huge cohort. And we looked, what's the difference? Of course, there are some patients who had stents, some patients who were managed only in medical therapy, and we'll talk about that. So again, they have blockages, 70%, at least one vessel, and they have what we call stable engine symptoms. And they looked over time, no difference. The lines, you see, the lines, they're meeting together. So the Courage trial proved for all of us, and that's why patients sometimes ask us, I have a blockage. Why shouldn't we stent that? Because it doesn't need to. You have stable symptoms. Stable symptoms on medical therapy. And that's, again, the 15 years follow-up. So the risk factors, a lot. And most of us know them. So the smoking, diabetes, the cholesterol, the high blood pressure, sedentary life, and family history. In cardiology and medicine, there are what we call modified factors and unmodified factors. I cannot change the genes. Maybe later, yes, they're working on that. And it's going to happen one day. So you can design your kids' or grandkids' genes. Would be cool. But not yet. So, and family history. We can't change that. It's tough. What we can change, habits. We can change a lot of habits. And I'll share something close with you here. My dad died at 52 of a heart attack at home after lunch with my mom. I cannot change my genes. I can't change how much I do, how much I eat, that's habits. Habits you can change. So we don't want anybody to come back here, right? But we have to have a medium line. So work, eat, sleep, repeat. That's our lifestyle, sadly. We're alcoholic. We're just workaholic every day. Yes. And I'm not breaking a secret if I tell that United States people are the least among internationally to take days for vacation, days off, right? There's a lot of data of that. So we'll work on that with our colleagues in DC, right? Okay, so, and this is another thing. Oh, I hope everyone had lunch, right? So, a lot of it, yes, indeed. Okay, it's everywhere. Vending machines. We rarely get hungry. Isn't that a fact? We rarely get hungry. Vending machines, buffets. It's amazing. Okay. Sodium. Recommendation for sodium, 2.4 grams a day. This is a study from CDC looking at consumption in the United States of sodium. This is the line of 2.4. Oh my God. Some people eat 7 grams of sodium a day. God bless buffets. Okay. Sugar consumption. And that's why I disagreed with Corey about the cookie. See the sugar consumption? It's taken off. Amazing. It's scary. It's scary. Okay. Daily vegetable consumption. We're kind of a greenish light. So you see the West Coast here. This is Washington. But look here. What just I told you? Death. Remember the death, heart failure? The least vegetable consumption. One fact. We're coming to a second shortly. Okay. How much we're eating home, how much we're eating fast food back in the days and now. 1977, 79 compared to 2005, 2008. The yellow bar is restaurants. And this purple, fast food. Wow. Yes, it's very convenient. It's very convenient. I understand that. We work so much. It's tough to have somebody if you have a spouse and a husband, both a man and his wife working. That's what we get to. Less people eating home. Less people eat. That's another fact. Okay. So I was born in Damascus, Mediterranean. I'm not biased against for Mediterranean diet, but this is the best diet if you want to go for diet. I hear about keto diet, I hear about other diets, about famous doctor diet, But this is what New England Journal of Medicine is one of the highest respectful journals in medicine in general. It's very prestigious. The studies are really great, and time after time after time, Mediterranean diet was the most effective preventive diet. Olive oil, nuts, garlic, as such. Not pasta. So, pizza. I was invited to an Italian friend. He's one of our doctors in the hospital, to his house, and he has a good oven. And he made a pizza. And then I was like, are you going to add some pineapples? And he looked at me full of anger. And I'm not going to say more. I don't know if some of you are Italian, but yeah, pizza is different in Italy. So, okay. This is my favorite diet. This is my best diet. Okay. Cost effective, right? Works, right? And definitely, you don't have to spend an effort. You don't have to look at literature. You don't have to look at books. You don't have to do much of effort there. Eat less diet is great. Believe me, try it. Okay. So, overweight. This is another staggering slide here. United States, 35% overweight. 35% overweight among population. And remember the mortality I showed you in heart failure slide? Again, look at the southeast states. Is that a coincidence? It's not.
What is the brown? What's the numbers on it?
More than 35% of population.
And Washington State is what?
It's good. I mean, the data here is better. It's almost this color, 25 to 30%. So,
Thank you.
more outdoors, I guess. Less humid weather, right? Okay.
Yeah.
Menopause and aging, coming back to women, yes, it can increase the risk of it. That doesn't mean pre-menopause women are not at risk of coronary disease. That doesn't mean that, because they have other risk factors. But once the protective hormonal cycle is not there anymore, yeah, they come high risk. So, physical activity. I'm going to share with you another story from the old country. And I have time, I guess? Okay, good. So, this is a grandfather telling me a story. They used to make shoes from the bottom of tires. So, an old truck tire, they take that and they make the sole of the shoes out of that. Every 6 months, they needed a new shoe. Any idea why? They walked a lot. So, we don't hardly, the shoe gets old nowadays, but your foot, you just get bored of it now more than. Okay, so there was, in 2018, a lot of ACC guidelines, American College of Cardiology, about physical activity. How much should I do? At least 4 or 5 times a week, 40 minutes, 40 to 45 minutes of vigorous exercise. And we'll talk about that. So, even look at this, preschool, they're coming to preventive now. We're talking about, we need to attack this much earlier than it comes to us. They should be physically active all day, not on their iPads, not on their YouTube. They're on their feet. 6 to 17, school age, do 60 minutes a day, vigorous, running, basketball. Okay, so general recommendation, 75 to 150 minutes a week of vigorous exercise. If you're talking about walking versus vigorous exercise. Okay, I walk, doctor. Try to walk every day. Great, that always helps. We're happy. We need you to walk. Walking, this is compared to do nothing. No prevention. If you do more vigorous exercise, the bars separate. Prevention as we go. More activity, more days, more preventions. Definitely. This is again a slide showing you, based on the state, how much physical activity. Again, we'll go back to that slide. Another fact, physical activity. Remember the slide about heart failure and death? Look here, where they're not active. We definitely have more risk of death. Okay. So how much should I burn? How much should we do? This is just, if you're doing just jogging, this is how much per hour, and you see how much difference if you do vigorous, even swimming and walking. The least, of course, burning of walking. Okay. So one Coke, regular Coke, is 120 calories, right? You need 1 mile of walking, 1 hour of walking to burn that. Okay. 448 calories for a burger. You need 30 minutes of boxing to burn that.
Boxing?
Yes, if you happen to do that. 2 slices of pizza, 30 minutes of professional biking. Running, vigorous running, of course, we're talking about 8 to 10 miles per hour, not 5 or 4 miles per hour. You need to burn that steak and kidney pie, 30 minutes. A lot of calories, a lot of that in our food, processed and all that. So it's the intake, the balance. Am I burning or am I gaining? Human, all of us, we need on daily basis of just office work, life just minimal, around 1,500 to 2,000 calories a day. That's if we do nothing. On average, in the United States, people have 1,000 to 1,500 calories extra a day. So every day, count that, every pound you gain, you can gain it over 5 days. 3,500 calories are enough to gain 1 pound. To lose 1 pound, you have to burn 3,500 calories, meaning you have to run at least 20 miles to burn that 1 pound. Okay. So, now let's talk about plaque, let's talk about the blockage, let's talk about prevention. And this is, of course, tension now I'm seeing my patient, it's tension in the room, patient is angry, I'm kind of protective. Statins. Oh, am I gonna fail my battle here? I'm sad when I do. I take statin myself. So it's always kind of warm discussion. We hear about literature. Everything we do, we don't do it based on experience. Every cardiologist, every physician should come from studies, clinical trials. We don't want to harm patients. We don't want you to ache. We don't want you to be sore. We don't want you to have diabetes or early dementia. We are aware of all this literature. We see it in our iPads and phones every day. This is a struggle we have every morning, every day, every week, at least myself. It's to keep up with literature, to keep up with the studies. Once we're out in work, we have to maintain our certification. And not only that, we have to meet the needs of the new medication, new era, new revolution of medicine. Statins are bad. They're not. I just named a study. We like names in cardiology, so we remember. So it's hard to remember this study, that study. S4, Prove It, Jupiter, Aurora. It's easy. It's like people name. We remember names. All those studies, thousands and thousands and thousands of patients. And that's where we come from as doctors. Statins can cause side effects. We're aware of that. And they can cause muscle degradation and breakdown. Yes, we're aware of that. Shy, very shy literature about diabetes and dementia. Very shy. Not really strong. The data is here. That's the strong data. So I pulled believe me, there are much more than that. But I don't want to make more busy slide than this. This is if you want that plaque to be stable, even in a young male or female in their 40s and 50s. So it doesn't rupture, it doesn't cause a massive heart attack. This is the key. So the lipids and the cholesterol buildup with calcium is not just the buildup. There is inflammation, active inflammation. So they went in and they did pathology in big centers and they looked at that precise plaque. There is inflammation, there is action. There is like a battle of macrophage and white blood cells with the crystals of lipids and make this action all the time. So that's what makes a plaque unstable, and nothing worse than an unstable plaque. Statins, however, made that plaque stable. So there are what we call number needed to treat. So how many patients should I give statin to save a life? Based on literature, 20 to 30. How many patients without statin I can do other medication to stop the plaque? It's hard to say. And we're going to talk about the other supplements. Okay. Now, does everyone needs aspirin? That's another slam we got us as heart doctors and cardiologists and physicians last year. A lot of patients are on aspirin. A lot of people are on aspirin. My doctor, or I took it because I know it's good, I know it's preventive, I heard this good thing about it. So again, coming from data, coming from literature, we don't want to harm people. So we had 2 studies last year, big journals. LANCET is a great journal, another one is New England Journal of Medicine. The first one is called Arrive, and the other one is called Ascend. So the Arrival study looked at aspirin, people taking aspirin for just prevention. And people are taking aspirin because they had coronary disease, they had stent, they had bypass surgeries, they have other problems. And they looked. So apparently a patient who didn't need aspirin, just taking aspirin as a prevention, bled, had more bleeding. So now we're not doing aspirin unless there is indication. So if you happen to take aspirin, just because, you don't have to anymore. So that's the latest, okay? That's the latest, okay. Okay, we all know about it. We all know about it. Q10. Does that help the plaque? Does that help the cholesterol? I took that snapshot from the National Institute of Health, so I can present the data. The data is not convincing, so we don't usually do it because we have to have a proven what we need to give our patients. Number needed to treat is not there. You can, of course, it helps economy, it helps cycling the money, it helps all that. I'm sure people keeping jobs because of this, but I cannot recommend that. I cannot. And that's when you show it to us, what do you think about this? We can't give an answer because unless we have proven benefit, we're not going to do it. Natural supplements. United States, number 1 in the whole world, taking natural supplements. Again, money circulation is great, all that. There are a lot of jobs kept of that. And that's fine. But, and this is just to cut it down based on age. Look, once we reach 65, more people eating supplements than young people. Women, taking more supplements. And of course, based on race, whites are taking more supplements. So, vitamin E, again, that's from JAMA. JAMA is a great journal as well. They looked vitamin E versus placebo, no benefit. No benefit. No benefit. Okay. Folic acid and vitamin B complex. No benefit. Okay. We do everything possible. We recommend and we do our best. But this is the key. This is the key, right? Okay. Of course, we try to build a relationship with patients. We try to be, when I go in a room, I don't stand. I try to sit down. I want to be an advocate. I'm not there to lecture. I'm not there to, people know what's right, what's wrong, mostly, right? We all know what's right, what's wrong. All of us are different. We have different circumstances. We have different life kind of dictating factors. So I want to be an advocate. I'm not there to lecture. I'm there to help. I want to listen more, and listening, believe me, was the key for more than what you think, and more than what even a stress test can tell me, more than what all other testing can tell me. That was the key. Not any medication. We know about side effects, but side effects, we can definitely try different statin. We have so many of them in the market. And they have what we call a class effect. So the first one caused the problem, second one caused the problem, third one caused the problem. We have what we call a novel therapy now. We have a lipid-lowering medication, injectable now. You can take it twice a month to lower your cholesterol levels and prevent farther events. We definitely need to help with that. Women are, yes, they have different symptoms, and of course, and that was reported, their symptoms were undermined before. Now we're definitely more cautious. We listen is the key. I'm gonna leave with just a quick, see, I always share slides about past, and I would like to, just because I'm here, I thought I can share this with you. So I was born in Damascus city in Syria, and most of us read the story, I hope, Road to Damascus, where Shaul, later called Paul, St. Paul, was walking to Damascus to persecute Christians there. And of course, the story tells the Christ appeared and had him blind there. And then St. Paul thereafter went to Damascus city, and he met this priest whose name is Ananias, and he gave him his vision back. And this is a church underground inside the walls of Damascus. Beautiful, small, but you can go and visit. A very humble, very kind of sacred place. And then, of course, they knew about him, the governors and the other people there, and he wanted to escape the wall of Damascus. So he descended from a door. You see that hole there, and basket. And that's what we call Bab Kisan door. And there's a church inside that door here, a small church called St. Paul Church in Damascus. So I lived 5 minutes away from that. Every morning I had to pass by history of thousand years. So I hope you enjoyed my talk. Thank you.